begin and
Yes, sir.
then
Okay.
good evening everyone, and let me welcome you all to this Thursday session of clinical sciences. Today we are going to do clinical science and we've got two speakers. First is Dr. Shrikant Deshmukh, who is a consultant neurologist working at Aurangabad, and he's one of our star students at JJ. And he will talk on two clinical signs. One is the mirror movements, and then he'll follow it up with the hermit sign. And then Dr. Girish Soni, who is now associate professor at the Grant Medical College, will show you various clinical signs. He's going to divide his presentation into two parts. Part one he'll do today, part two we'll do at another time. So let's invite Shrikant to start his presentation.
Yes.
Shrikant.
Yes. Uh, Thank you very much, sir, for the kind introduction, and good evening to all. So, yes, I'm starting my talk, clinical science in neurology, having two parts: mirror movements, which has a predominant section, and hermit sign will have few slides. So, to start with, mirror movements refer to involuntary movements on one side of the body which mimic voluntary movements of the opposite side of the body through the activation of homologous muscles that approach the performance of a specific task. So it's kind of a very busy definition, but it practically covers almost all the relevant points regarding the mirror movements. That it's basically involuntary movement on one side, which mimics the other side through activation of homologous muscles. Basically, they are distinct from dystonic limb movements. They are not classically, they are not dystonic limb movements. It is a soft neurological sign. So one needs to be, one needs to be very probing in the clinical assessment to get these mirror movements as a neurological sign. And first we should be aware of that entity in particular medical conditions so that we can look for it in various neurological illnesses. And mirror movements are commonly seen in the upper limbs, and in that also hands it is more particular. In the lower limbs it is seen, but it is very rare. So these are the few starting introductory points regarding mirror movements. Now, why mirror movements are important from patient's perspective? Because mirror movements can interfere with bimanual coordination. So there are a few case reports, very interesting case reports. For example, there was one boy uh, who was unable to climb vertical bars in gym because releasing one hand used to cause release other, so leading to fall and injuries. So again, a very practical problem. He could not do the gym activities because of these mirror movements. There was one other case where a 15-year-old girl with congenital mirror movements, she used to complain of painful contraction of the left shoulder muscle whenever she used to write with the right hand. Now, again, it is very strange, but it is basically a motor strategy adopted by that individual to counteract the mirror movements on the opposite side. So again, a very peculiar situation. The pain in the shoulder on the opposite side while writing with the other hand. And obviously, the day-to-day activities such as tying shoelaces, buttoning shirts, cutting vegetables can become very difficult in presence of these mirror movements. Now, physiological mirror movements may appear in infancy of healthy children and which may persist until the age of 10 years, primarily related to the maturation of central nervous system. Subtle physiological mirroring may be observed more on EMG, is seen in normal adults, and it is known to increase with fatigue and demanding tasks. So there are very subtle findings. It may not be very obvious. Now, when we consider the etiology of mirror movements, basically it is divided into three particular forms. One is physiological form, which we have just seen that it may last from the infancy up to the age of 10 years. Second is hereditary form, which we call as congenital mirror movements. It's generally autosomal dominant, but maybe few cases are recessive as well. and pathological causes where there are secondary causes such as stroke, CV junctions, movement disorders, and few others, so which will we look in detail. So going into the various entities that we need to know in our exams also, for a short note, that what all entities are associated with mirror movements, and the list is a little extensive. The common is agenesis of corpus callosum, various genetic disorders causing agenesis of corpus callosum, basilar invagination of the skull, and as well as few other CV junction anomalies, spina bifida, Kalaman syndrome, Friedreich's ataxia, congenital hemiparesis, schizophrenia, phenylketonuria is a metabolic disorder, CNS insult in the early life, and some extrapyramidal syndromes. Now, there are few conditions in which why it happens. Still, the pathogenesis is not yet known. Few entities are known which we will discuss, but few are others are there which we don't know exactly what is the etiology of the mirror movement. Now, whenever we talk about congenital mirror movements, it is said that persistence of ipsilateral corticospinal tract pathway is the main neural substrate in congenital mirror movements. Because whenever you, because this following finding of motor evoked potentials in the resting hand after stimulation of the ipsilateral cortex is seen in many cases of congenital mirror movements. So it justifies that this ipsilateral tract is probably responsible for the mirror movements in congenital mirror movements. However, in acquired mirror movements, most of the studies have shown that it appears to stem from an abnormal activation of the opposite side, contralateral to the contralateral to the mirror movements. So it's a very rough differentiating factor that congenital mirror movements, same corticospinal tract, and acquired mirror movements from the opposite cortex. Now, this is mechanism one. Now, as we can see here, uh, these are the two cortexes and these are the mirror movements. Now there is a homologous drive to bilateral motor neuron pools. So if this arrangement is seen, then probably you are dealing with congenital mirror movements. So the pathway has bilateral representation to homologous motor neuron pools, and which may give rise to congenital mirror movements. So this is pathogenesis, probable pathogenesis type 1. Now this is second. As we have discussed, the presence of ipsilateral corticospinal tract, which is uncrossed, it is implicated with these mirror movements of this hand and voluntary of this hand. So whenever there are voluntary movements, the mirror movements will come on this side because of this ipsilateral uncrossed corticospinal tract. So these first two mechanisms are generally implicated in congenital mirror movements. Now, congenital mirror movements, it is said that the gene DCC is responsible for formation of nectin-1 receptor, which binds to nectin like a lock and key configuration. And this binding modulates growth and development of axons and inhibit movement of signals to the same side of the body. So normally it inhibits, but if there is some problem, if there is some mutation in this configuration, it will cause impairment in this process and it will lead to bilateral transfer of signals instead of only on the opposite side. So this DCC gene has been implicated in congenital mirror movements, and the other gene responsible is RAD51 mutation. So these two genes are responsible for congenital mirror movements. As I told before that mostly it is autosomal dominant, but even few recessive cases are also observed. And the most important finding is no neurodeficit is generally observed in these patients. So despite the fact that patient has congenital mirror movements, you hardly see any neurodeficit. The imaging will be normal and there is no problem to the patient except for the mirror movements. Now, talking about mirror movements in acquired causes, so we come to Parkinson's disease. Now, it was initially described in 1928 in one of the paper, but till 1999, it was underappreciated till one biomechanical analysis has revealed the presence of mirror movements in Parkinson's disease. Now, what is important is that in Parkinson's disease, the mirror movements are observed only in early and middle stages and not in the advanced stages. So this factor we have to keep in our mind whenever we are seeing any PD patients, that it may be only observed in early or middle stages. Normally, in a typical PD, like a asymmetric PD, it tend to persist for at least 5 years into the progression of the disease. So from beginning till 5 years, it may last and then it may slowly subside. Again, as I told you, as mirror movements are more common in upper extremities, same applies in Parkinson's disease. These mirror movements are unilateral and they are observed in less affected hand during voluntary movement of the more affected hand. So whenever the Parkinsonian hand moves, the normal hand will show more mirroring in Parkinson's disease. Again, it is being noted that it is more prominent in those patients in whom levodopa response is greatest. And whenever patient is from off to on phase, during that transition, the mirror movements may appear more prominently. It basically relates to reduction in the bradykinase and rigidity of these patients due to levodopa and possibly increasing the prominence of mirror movements. Again, as we discussed, that it is from a crossed pathway from a opposite side, because most of the acquired mirror movements are coming from the opposite motor cortex. The second pathogenesis is decreased transcallosal inhibition. As we can see this dotted line here, the decreased transcallosal inhibition causes facilitation of this cortex and giving rise to motor movements on this side. So this is a voluntary movement and this is a mirror movement. So this cortex normally should inhibit via this pathway, but because there is a less inhibition across transcallosal pathway, this cortex will again give rise to mirror movements on the same side. Now, this pathogenesis is probably implicated in corticobasal syndrome. In many of the papers, it has been considered as a standard component of the clinical diagnosis of CBS. And it is seen in conjunction with other involuntary movements such as alien hand, myoclonus, etc. In contrast to Parkinson's disease, corticobasal syndrome associated mirror movements commonly occur in more affected side. In Parkinson's, we told it is in the opposite side, but in CBS, it happens on the same side. And for some unknown reasons, we see many patients of CBS who have affection of their left side. The reasons being unknown, but the left side is commonly affected as compared to the right. Again, as we discussed in the last slide, the thinning of corpus callosum and inhibition of impairment of inhibition is probably the mechanism involved in CBS. Now, again, there are a few studies which show us that mirror movements can happen in essential tremors. The fact is, if they are present early undiagnosed, if they're present, they represent early undiagnosed PD, given that some cases of ET may go on to represent PD. So there is some confusion regarding whether the patients who are having mirror movements will eventually go on to have PD in a due course of time or not. But maybe a few studies will clear this aspect. The other mechanism is altered intrahemispheric inhibition of intracortical facilitation of cortex. So this altered inhibition will again cause this mirror movement. So by and large, what we see that all the mirror movements are coming from the opposite cortex. The mechanism may be anything. It may be just transcallosal, it may be intracortical inhibition, but it is coming from the opposite cortex. So we come to the mirror movements in focal hand dystonia that mainly we see in writer's cramp. Now, this mirror dystonia in writer's cramp, it represents a expression of motor overflow. And these mirror movements or mirror dystonia is seen in up to 50% of patients of writer's cramp. Again, as we know, whenever the patient is asked to perform a specific task by the unaffected hand, suppose patient has a writer's cramp on the right side, you ask the patient to write with the left hand, and then when you see the appearance of dystonic movements on the affected hand, it is a mirror movement which you are looking for. So basically, writing with non-dominant hand will give rise to mirror movements in your dominant writing hand. Why it is important? Because it helps to increase the accuracy while injecting botulinum toxin in writer's cramp patients. So it gives you more sense of accuracy and more confidence while injecting in these patients. And the functional MRI in these patients have shown bilateral cortical activation. So whenever there is a writer's cramp, there is a bilateral cortical activation. So it again suggests there is an altered interhemispheric inhibition. So as we have seen in this video, this patient has a flexor type of writer's cramp in the right hand. His wrist is flexed, his thumb is flexed, his index finger is flexed. Also, there is an abduction of the shoulder joint, so it is overflowing into the proximal muscles as well. So when we are looking for mirror movements, I ask the patient to write with the left hand.
किंवा असं खाली ठेवला तरी चालेल असं आता थोडं वर करा, हात थोडासा वर करा, आणि लिहा. थोडं फास्ट लिहायचा प्रयत्न करा, काही लिहा, थोडं फास्ट लिहायचा प्रयत्न करा. जस्ट राईट व्हॉट युअर.
So basically this video tells that there are mirror movements prominently in his thumb and his index finger where it is getting flexed. So FPL and FDS are getting activated along with some component of flexion in the wrist also. So we are quite sure that it's a flexor type of dystonia in this patient. So selecting the muscles, it becomes very easy when you find this kind of mirror dystonic movements. Again, this next video will classically tell you that this patient has been asked to write with the opposite hand, and what we can see is the classical mirror dystonic movements.
Start writing, madam.
So this is a very classical mirror dystonia, predominantly affecting the index finger and the thumb, with some flexion of the other fingers as well. So this is the chart where you see the mirror dystonia in what type of mirror dystonia, and then accordingly you can select the different muscles and the different dose, and obviously the benefits are marked when you find the mirror dystonia. Now, these mirror movements are also described in Huntington disease and along with the chorea. And the important thing is they tend to decrease with increased voluntary force. Now, this is one finding which is as opposed to general population in other cases where increase in the effort or attention tends to aggravate mirror movements. But in Huntington's disease, it is known that it reduces the intensity of mirror movements with increase in the voluntary force. Now coming to the mirror movements in stroke, there is very one good paper, review article, which has shown that probably the cortex is not the source of mirror movements in cases of stroke, and they say that there is a evidence that it is possibly a subcortical origin rather than a cortical origin. Now this paper basically tells us 3 points. First, the mirror movements were characterized by recruitment of multiple fingers. So individual finger was very rare. Whenever there are mirror movements, multiple fingers were recruited whenever there are mirror movements. These movements appeared early after the stroke in few days, and they normalized over a period of a year. Maybe in 12 months, they normalized. And when they do a functional MRI, they found no modulation of activity in the bilateral cortexes after stroke. So again, it is very unusual that the patient has mirror movements, but the fMRI did not show any cortical activation. So these are the 3 takeaway points from this paper. Now there is one other paper, not paper, it's a case report, but it's very interesting. As you can see, this patient has a stroke. It's a left paretic hand. And as you can see, the distance between the thumb and the index finger is quite low, while the mirror movement, the distance is quite high. As the disease advances or duration increases, the paretic hand amplitude increases, the distance between the finger increases, and the mirror movement distance keep on reducing. So as you can see here, that this hand is now at the end of 1 year is having a large excursion, while the mirror movement excursion has remarkably reduced in distance. So it's very interesting finding. Maybe we can look for this finding in all our stroke patients to look for mirror movements, particularly in the early part of stroke in a normal hand. And this is the same patient having this graph where the mirror movements gradually kept on decreasing, whereas the paretic hand gradually had increase in the excursion. Now, this is one case. She had a congenital left hemiparesis, probably some cerebral palsy like event.
करो 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 जल्दी जल्दी करो
Whenever she used to do this,
करो जल्दी जल्दी
the movements used to appear in this
ऐसा ऐसा करो
normal hand, right hand.
एक ही हाथ से करो
And she just continued with the right hand. Whenever there are
जल्दी जल्दी
these
करो
movements will appear on the right side, normal side. So basically, there was this one paper that when we are talking about the congenital hemiparesis or cerebral palsy, is there any correlation of the type of injury or the pattern of injury? So what the paper has mentioned that these movements are more common in the unaffected hand. Like in this case, they are more common on the right side. This left was the affected side. The mirror movements are common on the right side. Now, it has been known that patients with congenital hemiparesis have more pronounced mirror movements compared with those who have acquired brain insult. So possibly this is related to structural reorganization of corticospinal tract early in the life. So that's why they have more pronounced mirror movements as compared to the acquired cases. And the interesting point was the location of structural abnormality has failed to show any correlation with the timing and intensity of mirror movements. So it doesn't matter whether the patient has a gliotic area in a particular area of the cortex. The intensity and the timing of the mirror movements has not shown any correlation between that. Now, this was a case when I was doing my super specialization at Grand Medical College. Dr. Khadilkar sir has seen this case, and he had provided us an opportunity to write this short paper with Dr. Nilesh Nadkarni sir. So this was an interesting case. I think probably first time we encountered a mirror movement as a clinical sign in our medical education.
ये साइड से टैप करिए, हाँ करिए। अभी ऐसे ही लगे।
So basically, this girl had these typical mirror movements of the normal side, and the evaluation of this case showed the presence of abnormalities in the form of fused cervical vertebrae C2, C3, C5, C6, as well as atlantoaxial dislocation, and this was probably the consequence having these mirror movements. So finding this mirror movement helped to diagnose the congenital abnormality and probably get her operated. So there are a lot of papers which have time and again showed a very strong association of these CV junction anomalies with the presence of mirror movements. And depending on the cervical cord neurosis, there was a grading that normal cord deformity without cleft, posterior cleft, anterior cleft with or without posterior cleft, bow tie configuration, and complete neurosis. So as you can see, this is a normal spinal cord. This is just the anterior cleft. This is posterior cleft. This is grade 3. This is bow tie configuration. And this is complete grade 5. So basically the point is any mechanism, this is a normal, A is normal, B, C or D, any mechanism will be implicated. As we can see, the bilateral signal drive or both the sides, it is crossing on opposite side, or this same drive giving rise to opposite cross innervation. So it has not been very clear that what exactly leads to mirror movements in these cases, but any of this mechanism is probably related in having mirror movements in cases of CV junction anomalies. So now coming to the next sign, which is a Hermit sign, also called as a Barber chair sign. It was first described by Mary Chatelain in 1917, but it was properly evaluated and named by a French neuropsychologist, Jean Hermit, in 1924. And as we know, the definition of Hermit sign is transient sensation of an electric shock-like sensation extending down the spine or extremities upon the flexion of the spine. So this is a classical definition, and it's a paroxysmal pain syndrome. It comes and goes. The pathophysiology, by and large, has been distortion and demyelination of lower brainstem and cervical dorsal column sensory axons. There are some case reports which have also mentioned thoracic cord also, but the literature has prominent cases involving lower brainstem and cervical dorsal cord. And the spread of ectopic excitation will lead to the presence of Hermit sign. Now, the causes are, the list is very extensive. As we know, it's one of the hallmark clinical feature of multiple sclerosis seen in up to 33% of these patients. However, in neuromyelitis optica, the prevalence of Hermit sign may be higher as compared to MS. Cervical spondylotic myelopathy is other cause. Subacute combined degeneration of spinal cord, which we know very common. Radiation myelopathy. In this scenario, it usually takes 3 to 4 months after the exposure of radiation for Hermit sign to develop. High dose of chemotherapy. There are multiple case reports mentioning cisplatin and docetaxel causing Hermit sign in many of these patients. One of the peculiar condition is SSRI discontinuation syndrome. If all these SSRIs they're stopped abruptly, patients may experience Hermit sign in the due course of time. Fluoxetine has a very less incidence of causing Hermit sign because of the longer half-life. Few other causes are transverse myelitis, Behçet's disease, Arnold-Chiari malformation, SLE, syringomyelia, nitric oxide inhalation probably related to B12 depletion. So these few are the causes implicated in Hermit signs. Now, what we generally do when we encounter a patient with hermit sign is get an MRI cervical spine to look for any structural abnormality, any compression, any lesion, any plaque. If MRI spine is normal, again we can go for a somatosensory evoked potentials, median and tibial, look for any prolongation of the cortical and cervical latencies. As far as the treatment of hermit sign is concerned, symptom is concerned, oxcarbamazepine, pregabalin have been tried, many other drugs have been tried. Cervical collar or brace has been used for in some cases. However, one must be careful in avoiding the excessive use and cause wasting of these muscles. So it should be very calibrated properly by occupational therapist. And one of the therapeutic entity called as pulse electromagnetic field therapy has been used in some cases of patients with hermit sign. Normally, this hermit sign tends to subside within 6 months. So it's kind of it will not persist for a longer time. It has got a certain time frame in which it will go away. Now, to conclude in the final slide, there are two variants of hermit sign. One is a reverse hermit sign, in which the symptoms are induced by extension of the neck. Now, it is seen with extrinsic compression of the spinal cord. And the other is inverse hermit sign. It is like upward moving paresthesias instead of downward moving paresthesias. It is reported with nitric oxide inhalation and possibly B12 depletion. So for exam purpose, you can know of these things, because in practicals you may be asked about reverse and inverse signs. So that's it. So to conclude, I'll leave behind with you one very nice video from a Green Journal, where this boy who wanted to be a piano player, who was very fond of playing a piano, but because of these unwanted mirror movements, he had to become an opera singer. And you see why he could not pay. So this poor chap was not able to play piano. So he shifted his focus and became an opera singer. So it's one of the nice video. So thank you very much for your kind attention, and we would like to have any discussion regarding these movements, because it's a very unique topic. It's not a very common topic. So the literature is not very much. It's a scarce literature, and it is an evolving entity. So thank you very much, sir. So thank you.
Yeah, Shrikant, it was excellent.
Yeah.
And there are a few questions.
Yeah.
How do you manage congenital mirror movements?
Sir, it has not been, the data is very limited about the treatment of these congenital movements. I mean, I could not find any specific reference for that, actually, treatment of congenital mirror movements. So like in this case, I mean, he had to change his occupation, actually.
Okay. And there is one more. How do you differentiate clinically physiological, hereditary, and pathological mirror movements?
So it will be difficult to differentiate physiological and hereditary in the earlier part. But as we know, if in hereditary, there will be some family history. So you may get any clue that it is familial. If it is physiological, then as we know that it will go away after a certain age, actually. But if it is persist after 10 years, then definitely it is not physiological. And then you need to be aware that if there is anything else. And the thing is, as we know, in congenital mirror movements, you don't find any neuro deficit. So only the family history will help you in differentiating physiological and congenital in early part, and possibly getting genetic analysis if there is a strong family history, and doing a DCC gene and RAD51 gene analysis if it is available.
Yeah, perfect. Absolutely perfect. So I think we're through with the questions. So should we invite Girish now?
Yeah.
Yep.
So I'm stopping the share, sir. Yeah.
So now we hand over to Dr. Girish Soni. He is a professor of neurology at Grand Medical College, Mumbai. And as you will hear in the talk, he is an excellent clinical man, and you will learn a lot about clinical science, how to pick up these signs quickly, So, Girish, you ready?
Yeah, are you able to see my slides, sir?
Yeah, it is seen.
Seen?
Yes.
Yeah, yes, Girish, go ahead, please.
Yeah. So we are going to discuss all the science in 2 sessions. So part 1 and part 2. In part 1, I will try to finish science in higher mental function, dementia, and various movement disorders. Apart from this clinical science, we will try to cover a little bit of clinical aspect of many disorders.
Girish, sorry, I sort of I'd gone out and come back in a few.
Okay, sir. Yes, sir. Sorry. Yes, sir.
Just give me 30 seconds.
Yes,
there
sir.
are some senior people in the audience. I see Keyur Boch, P.T. Acharya, Ashok Shirsar. So any one of you want to teach something, please let us know and we'll bring you into the panel and you can tell about your experiences. Yeah.
Yes, sir.
So sorry. Yeah.
So this 72-year female, she presented with progressive history of memory deficit along with mild frontal impairment. And when I asked her particular question, just see what she does. Where is your home? Where is your home? Where is your home? So when I asked her question, she tried to take the help of her daughter. So this is head turning sign, which is a simple rapid test for diagnosis of Alzheimer's disease. It has a high specificity for around 90% with sensitivity around 60%, and it can be seen in 50 to 60% cases of amnestic variant of minimal cognitive impairment. And almost always this Alzheimer patient, they always come with the relatives, and that is called as attended with sign. And the main history is given by the relatives, not by the patient. And when you tell the patient of memory, when they come to you and they say, I'm having memory problem, doctor, I'm having sleep problem, lab, then this is called as attended alone sign. Even if you request them, please come with the relative, they still come alone and they tell you, I'm having memory problem. So this is pseudodementia. And this attended alone sign, it has a sensitivity for diagnosis of pseudodementia almost 90 to 95%. In moderate to severe Alzheimer, you get classical atrophy of the hippocampus, which looks like elephant trunk, and this is called as elephant sign. This elephant sign is not seen in MCI or early Alzheimer. It is seen in moderate to severe Alzheimer. But remember, please, this such temporal lobe atrophy can be seen in other dementia. You need to fit this imaging finding with the clinical context. If you give full empty page to the patient and request them to copy alternately square and triangle, just see how they draw the alternate square and triangle. If they draw near to the sample copy, then it is called as closing in phenomenon or Mayer-Gross sign. And this Mayer-Gross sign is seen in many patients of Alzheimer's dementia. It is rare or not seen in vascular dementia. It is due to combination of visuospatial disorientation as well as construction apprehension, mainly because of right parietal lobe dysfunction. This closing in phenomenon, they are of 3 types. Overlap is most severe, followed by adherent, followed by near type. Near type is mild, I mean to say, and it is most common type of.
Girish.
Yeah.
Girish.
Hello.
Yeah.
Dr. Girish,
Yeah.
your slides are very, very blurred. Hello.
Yeah. What I should do then?
Yeah, so you can stop sharing your screen and share it once again. I'll tell you one small check we need to do.
Do share. How to stop sharing?
Stop share.
Where is the option stop sharing?
Yes.
Yeah.
Okay, 1 minute.
Yeah.
So just click on the share screen button once,
Yeah.
and where you see the blue share
Advanced.
button.
Uh-huh.
No. Where you see the blue share button, at the same level on the left hand side, you have optimized screen sharing for video clip. You need to uncheck that.
Okay. Right.
Uncheck and then share again your
Yeah.
slides.
Now better seen?
Yeah. Yes, Girish. Now it
Yes,
is better.
yes, yeah. Now it's clear.
Okay. So this closing in phenomenon, there are three types. Overlap, which is most severe. The patient draw on the target figures as shown in this figure. Then adherent type, here the patient draw very close to the target without overlapping. Then the near type, which is a mild variant, where patient draw near the target at the end of the task. So this closing in phenomenon can be seen in Alzheimer, and you can monitor the severity of Alzheimer on the basis of this closing in phenomenon also, from near type patient progress to adherent type, then to overlap type. This alternate square angle test can be used to test the writing preservation or graphic preservation, which is mainly because of frontal lobe dysfunction as a result of loss of disinhibition and executive dysfunction. So this graphic preservation can be seen in many types of dementia like FTD, Alzheimer, as well as vascular dementia. The main use of this test is to monitor the frontal executive dysfunction throughout the disease course. As the disease progresses, it becomes bad. So this 75-year elderly female, she presented with history of progressive language problem in the form of progressive difficulty in understanding, progressive difficulty in naming the object. So suspected case of semantic dementia, which is like Wernicke's aphasia. Semantic dementia is a variant of frontotemporal dementia where we get Knipage atrophy of the anterior temporal lobe. In advanced semantic dementia, you get involvement of frontopolar part as well as hippocampal part. So please see the video. In this video, you have to look for two components. Number one, her language, and number two, the question asked to her.
कौन है?
माझ्या आई
अच्छा
कौन है?
माझ्या असं स्वतःच बोलायला आरशी यायला मला मला काय नाही कोण नाही
शकुंतला कुठे शकुंतला
माझ्या
कौन है ते?
ते काय 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 करत नाही काय नाही हाय माझी आई आहे.
So this is called as mirror sign.
Girish,
Inability to.
She's speaking in Marathi, so you want to explain?
Sir, I have one more video.
Okay, yeah.
This female, 60-year female, presented with history of recurrent visual hallucination, along with mild Parkinsonism, along with REM sleep behavior disorder. Classically, the picture of diffuse Lewy body disease, along with some fluctuation in the cognition. And just see.
अभी कौन है? कौन सी औरत है सामने?
वो चूनच है वो।
कौन है
वो क्या मालूम कहाँ से कि मेरे को नहीं मालूम।
नाम क्या उनका?
उसका उसे पूछो नाम क्या नाम है।
क्या है बताइए ना, कौन है मिरर में? कौन है मिरर में? कौन है आईने में? कौन दिख रहा है?
मेरे को तो डर आती आके घर में ऐसा।
ये कौन है? ये इसका नाम क्या है?
क्या मालूम पूछो उसे, मैं नहीं मालूम उसका नाम क्या है।
इधर है? इधर है वो? कहाँ पे है फिर वो? कहाँ पे दिख रही है?
क्या मालूम
किधर दिख रही है आप बताइए।
कौन वो? यहाँ दिख रही इधर।
So should I explain first video, sir? It's fine.
Very briefly, yeah.
So when I asked this lady who is seen in this mirror, she is not able to recognize self. In fact, she tells she is my mother. And though she is able to understand single step, double step command, her complex understanding is definitely impaired. At the same time, she is having some naming impairment also seen in this video. So this is a female of semantic dementia, and this is a female of diffuse Lewy body disease. And this is
अभी कौन है?
inability to recognize self in the mirror, and that is called as mirror self agnosia or mirror sign. Sometimes this patient develop delusional belief that their reflection in the mirror is in fact that of stranger, and this is called as phantom border sign. Basically, this is because of impairment in the perception of the face as well as their affective and reasoning deficit. In fact, right posterior hemispheric dysfunction or right parieto posterior temporoparietal dysfunction. It is commonly seen with diffuse Lewy body disease and semantic dementia and in posterior cortical Alzheimer disease. Basically, there are 4 types of Alzheimer disease. For theoretical purpose, I am telling for students, 80% of Alzheimer patients, they typically present with progressive memory deficit, that is amnestic variant of Alzheimer disease. 10 to 15% of patients, they present with occipital lobe deficits like visual agnosia, prosopagnosia, color anomia, as well as mirror cell sign with minimal memory impairment. The memory impairment comes late into the disease course, and that is called as posterior cortical AD or Benson syndrome. Third variant is frontal variant of Alzheimer disease, which is called as Johnson syndrome, where patient have prominent behavior problem and personality problem along with memory problem. It looks like FTD. And fourth variant is logopenic variant of Alzheimer, where patient have prominent repetition impairment along with naming deficit. So this logopenic dementia, it is like conduction aphasia, where repetition is markedly impaired. While in semantic dementia, the repetition is relatively preserved. While there is one more aphasic variant of dementia, we call it as a non-fluent primary progressive aphasia, which is again a variant of frontotemporal dementia, which is like Broca's aphasia, where patients have prominent non-fluent speech along with naming impairment and mild repetition impairment. So remember, logopenic aphasia means variant of Alzheimer with impairment of conduction deficit. I wanted to tell one more sign which is described on PET scan in DLBD patients, cingulate island sign. So in DLBD patient, you have marked hypometabolism in occipital lobe, going into the parietal lobe along with basal ganglia hypometabolism, but posterior cingulate gyrus is very well preserved. So this is posterior cingulate island sign. While in Alzheimer, you get early, very early or earliest part of the brain which undergoes hypometabolism is posterior cingulate gyrus along with medial temporal lobe. Common finding on PET scan in Alzheimer patient is hypometabolism of temporoparietal area along with posterior cingulate area. Later on, frontal lobe is involved. Very last to get involved is occipital lobe. While in DLBD, you get very early involvement of occipital lobe. So please remember cingulate island sign on PET scan. It is for DLBD. While seeing this video, please check how Dr. Vikram is moving his key as well as look at the mentalis muscle. I'm demonstrating it one more time. So this is palmomental reflex or mental sign, which is a type of frontal release sign apart from glabular tap sign, snout reflex. So basically here we stimulate the thenar eminence, which cause involuntary contraction of unilateral or bilateral mentalis muscle. Please remember, in 5 to 50% of patients, this palmomental reflex can be physiological, but it is a vehicle response. It shows fatigability with repeated stimulation, and here the reflex trigger area is only thenar eminence. Well, what is pathological mental sign? Here the response is stronger and it doesn't show fatigability, and hence you have to always give 5 or more stimulation to differentiate it from the physiological palmomental reflex. And always try to demonstrate this reflex by stimulating the other trigger area like hypothenar, thumb, chest, etc. So here the reflex trigger area will be much wider. Apart from thenar eminence, you can stimulate this reflex with other areas also. While in physiological, only thenar area will bring this reflex, and that is again weaker with evidence of fatigability. So this 55-year gentleman presented with progressive behavior problem, personality changes, with tendency for sweet foods, with minimal memory impairment. So while carrying out detailed examination on examination table, just see what he is doing. One spectacle. Behavior sign, which is basically described by Lhermitz. It is also called as Lhermitz sign of cognition. What is frontal utilization behavior disorder? Here the patient uses object appropriately, but in an inappropriate situation. Whatever comes in their visual, tactile presentation, they grasp them and try to use them. And it is seen with frontal lobe dysfunction, very commonly seen in frontotemporal dementia, and in advanced cases of dementia, whenever advanced cases of Alzheimer dementia, whenever frontal lobe is involved. In this video, I am going to show two classical signs. Please look at his left hand, as well as whatever instruction we are giving, how he is trying to follow all those instructions. And at the end of video, he utters something. Please try to listen that.
राइट हैंड से सलाम करके दिखाओ. सलाम कैसे करते हैं? सलाम कैसे करते हैं? सलाम सलाम. ठीक है ठीक है ठीक है, नीचे रखो. ब्रश करके दिखाओ. ब्रश राइट हैंड से ब्रश कैसे करते हैं? हाँ करो. ठीक है, नीचे रखो. लेफ्ट हैंड से करो. लेफ्ट हैंड से सलाम करो. अच्छा ठीक है. आंखें बंद करो. बंद रखो आंखें.
Should I play one more time video, sir? Or fine?
No, yeah, it looks good. Yeah.
Fine.
It is fine, I think. Yeah.
So whenever we ask, we already teach him how to do brush, how to do salam, but still he is making mistake with his right hand. So this is classically ideomotor apraxia. But at the same time, his left hand is going automatically up while doing activity with the right. And when we ask him to perform the action with left hand, he is saying, I'm not able to do it. And at the end of the video, he says, automatically my hand is going up. So number one, ideomotor apraxia, that is evident very well. And second sign is alien hand sign. Classical parietal alien hand, which is defined as complex, involuntary, goal-directed activity of one hand, along with denial of ownership or feeling of foreignness. As he is saying in the video, अपने आप ऊपर जा रहा है, पता नहीं मुझे. I don't know why he is going up. So this is classical parietal alien hand. Various books has described or given various definition of alien hand. So please remember simple definition: complex, involuntary, goal-directed activity of hand, along with denial of ownership or feeling of foreignness. So this is definition of parietal alien hand. There are various types of alien hand. So I will spend some time here because the concept of alien hand is very difficult to understand from the books. Let's divide this alien hand into three types: parietal, frontal, callosal. The parietal alien hand, they are of two types: typical parietal alien hand, a typical parietal alien hand. So what we saw in this video is typical parietal alien hand, which usually affect the left upper limb, where along with this, the patient also have cortical sensation impairment in the left upper limb, and left upper limb, it perform involuntary movement which is goal directed, and they say, I don't have sensation of this limb. This limb seems to be foreign to me. So this is typical parietal alien hand. Then second is callosal alien hand, which is also called as diagnostic apraxia, and it is typically pathonomically characterized by intermanual conflict, where if you ask to do patient some action, the left hand will perform completely opposite action to that of right hand. For example, suppose the right hand opens the door, the left hand will close the door. If right hand opens the ball pen, the left hand will take the ball pen, may throw the ball pen from right hand. So this is callosal alien hand, which is also called as diagnostic apraxia. What is frontal alien hand, which is also called as anarchic hand or wayward hand? It is extension of frontal behavior utilization sign, where patient try to group, grasp whatever objects are there around them. They try to compulsively manipulate various tools which are there in front of them, but they doesn't give history of disownership of the hand, or they doesn't have intermanual conflict. Disownership of hand is typically seen with parietal alien hand, while intermanual conflict is typical of callosal alien hand, while frontal alien hand is just compulsive manipulation of tool. Whenever there is extensive involvement of frontal lobe along with callosum, just like butterfly glioma or lymphoma going into the callosum, corpus callosum from the frontal lobe, having extra extremities, 3 extremities, 4 extremities, and it is called as supernumerary hand, which is a variant of severe frontal alien hand. So please remember 3 variant of alien hand: parietal, callosal, frontal. In this video, I am going to show a typical parietal alien hand, which is also called as
आइए चल के
It is a case of
आइए चल के हाथ छोड़ दीजिए, हाथ छोड़
palsy. You can see markedly reduced blink rate,
आइए
direct posture, direct neck, over contraction of the frontalis muscle.
आइए
So
आइए
involuntarily
चल के
while
हाथ छोड़
walking,
दीजिए,
his
हाथ
arm
छोड़
is going backward and upward.
आइए
Involuntary aimless arm levitation while walking or doing activity with the right hand, but they don't give history of disownership of the upper limb or feeling of strangeness like typical alien hand history. It is typically seen in corticobasal ganglionic syndrome, also in PSP. So it represent posterior variant of the alien hand, just we discussed, and it is because of right parietal lobe dysfunction. In this video, we are going to see 3 classical signs of right parietal lobe dysfunction.
पहनो शर्ट तुम अकेला कहाँ गए? अकेला और इसे जानते हो, श्रुति, अकेला सब? उनको बोलो पेशेंट आके देखे।
अकेला
सबको, अकेला, श्रुति, शालिनी,
सब अभी सीएमई में सर ऊपर।
ओके,
उनको बोलता हूँ
बाद में। पहनो साहब शर्ट। कहाँ से पहनते हैं शर्ट? हाँ सिस्टर ने पहनो साहब, बराबर, वेरी गुड. So see how severe is the stroke.
If you look at him, it doesn't look that severe, but neurological changes are there.
So all these are classical signs of right parietal lobe dysfunction. In this video, we can see dressing apraxia, drawing or construction apraxia, as well as hemineglect. First video.
ऐसे ताली मारिए.
So this is
ऐसे ताली मारिए.
Applause sign or 3 cap test, which is again motor preservation. It represents motor preservation. Can I ask one simple question to all senior faculty, whether to ask the patient to clap rapidly or slowly? Khadilkar sir. Sir, I really don't know. Some examiner they say rapidly, some examiner say slowly. Who told you rapidly? That's why.
Some people say that it has to be slow, but I haven't found a difference. If it's positive, it's positive. Yeah.
Okay, so one patient I showed with slow clapping, other patient in the video I showed with rapid clapping. So ask the patient to clap 3 times. If person is unable to inhibit after 3 clap, it is called as applause sign, which is very sensitive for progressive supranuclear palsy, but not specific. Because it can be seen in apart from PSP, it can be seen with corticobasal degeneration, frontotemporal dementia, advanced Parkinson disease, as well as Huntington disease. Sometimes it can be seen in vascular dementia also, basically because of frontal and basal ganglia connection dysfunction, because of loss of inhibition. A typical picture, typical sign seen in PSP, dirty eye sign. Because of vertical eye movement problem, while eating, patient frequently soil their cloth with food, and this is called as dirty eye sign or sloppy eaters, seen in PSP. Procerus sign again described with PSP, which are nothing but a vertical wrinkles at the nasal bridge, and it is basically described as because of dystonic contraction of procerus muscle. But these vertical wrinkles, they are caused by dystonia of corrugator supercilii muscle, not procerus muscle. Procerus muscle dystonia will cause horizontal crease over here. So basically this should be the procerus sign and this should be corrugator sign. But still we label this as a procerus sign. So please remember, procerus sign is because of corrugator supercilii muscle, and horizontal crease ideally because of procerus muscle dystonia you will get here. Other signs in PSP, astrologer face with marked reduced blink rate with surprising look, typically seen in PSP with unequal dystonia of the frontalis muscle. Sometimes the frontal unequal dystonia of the frontalis muscle can give rise to omega sign over the forehead, again seen in PSP. Please see this video. In this video, I will show the video and then I will describe it.
Very good. Kara uta. Basa आता. Basa patkan.
So this in PSP, because of frontal lobe dysfunction or frontal lobe involvement, they suddenly try to get up from the chair without foot adjustment. And because of marked postural instability in PSP, which is because of pedunculopontine nucleus affection, in addition to basal ganglia affection, they tends to lose backward. So because of frontal dysfunction, they try to get up fast without foot adjustment. And because of postural impairment, they fall like a duck on the chair. And this is called as rocket sign, seen in PSP patients. The other signs described in PSP are round the houses sign, arm levitation sign we already saw, and pillow sign. We'll see all these signs. On imaging, typically you see atrophy of the midbrain tegmentum, hummingbird sign. Also, in early PSP, the superior colliculus, it undergoes atrophy. And this quadrigeminal plate looks like a shoe. So whenever there is vertical gait impairment, or whenever you are not able to see hummingbird sign, please see superior colliculus. It will be atrophic as compared to inferior colliculus. So shoe-like appearance of the quadrigeminal plate can help in diagnosis of PSP if there is no hummingbird sign or penguin sign. While morning glory sign or Mickey Mouse ear sign, which is because of marked concavity of the midbrain in the axial curves, try to connect the inferior or superior colliculus with the lateral border of the cerebral crux. If the middle part of the midbrain is not falling on this line, then this is PSP or Mickey Mouse ear sign. So sometimes we may not easily appreciate whether it is really atrophy of the midbrain tegmentum or no. So try to connect this point along with this point. If this is not coming on this line, means it is Mickey Mouse ear sign and PSP. On PET scan, you will get one more sign in the form of hypometabolism in the midbrain and pons because of pedunculopontine nucleus affection, and this is called as pimple sign. So pimple sign on PET scan is again one hallmark for PSP diagnosis. So while testing for vertical saccades, instead of taking classical vertical path, just see how the eyes are going.
खाली बघा, वरती बघा, डावीकडे बघा,
horizontal eye movements preserve.
खाली बघा, वरती बघा, खाली, वरती, खाली बघा.
So this is round the houses sign, not round the house sign, because there are two orbits. So while testing for vertical saccades, remember the round the houses sign should be checked while testing for saccades, not while testing for vertical pursuits. So instead of moving vertically, the eye will take lateral or oblique arc while doing for vertical saccades. So this is round the houses sign. I think this sign I will not show. The pillow sign again can be seen in PSP patient. It is because of dystonia of the neck muscle. If you remove the pillow from the head of the patient, the head will remain like this only. So this is a pillow sign seen in PSP patients. Classical PISA sign seen in MSA patient. So what is PISA sign? It is also called as Igboms sign or pleurototonus. It is tonic lateral flexion of the trunk because of dystonia of the trunk muscle, where patient lean on one side. At least 10 degree of lateral flexion is needed to label it as a PISA sign. It is seen in MSA patient, can be seen with neuroleptic induced akinetic rigid syndrome, can be seen in advanced PD. So it is not specific for MSA, though sensitive. In 50 to 70% of MSA patient, because of autonomic dysfunction and impaired neurovascular function in the fingers and hand will be cold, red, dusky, with delayed capillary refill, and this is called as cold hand sign seen in MSA patient. Well, because of again autonomic dysfunction and postural hypotension due to hypoperfusion of the craniocervical muscles, they give history of craniocervical pain, typically in the distribution of coat hanger. And this pain is more in the morning after awakening, after exertion. And this is called as coat hanger sign or coat hanger pain, seen in 40 to 50% of MSA patient or those MSA patients who have obvious postural hypotension. And on imaging, in MSA-P, you get putaminal slit sign. About this putaminal slit sign, particularly on 3 Tesla MRI, see, usually it is bilateral, usually it is asymmetrical. In advanced cases, it can be symmetrical. It is not uniform. While physiological slit will be uniform on 3 Tesla MRI, you may get. While pathological slit will have variable thickness. More thick in the posterior part, thinner in the anterior part, and they will be little asymmetrical. While in MSA-C, you will see a hot cross bun sign because of degeneration of the transversing cerebellar fibers, myelinated cerebellar fibers, as well as you can get MCP dot sign, which is not shown in this MRI, but hyperintensity of middle cerebellar peduncle. So hyperintense MCP sign, hot cross bun sign, MSA-C, putaminal slit sign, MSA-P. Again, this is a frontal release sign where you have to tap in the glabellar area at a rate of 1 tap per second and look for the blinking, habituation of the blinking. Normally, most of the patient, they overcome rapidly. But if they fail to stop the blinking for more than after 5 tap, then it is pathological glabellar tap test or Meyerson's sign. So it shows fatigability again. If it persists after more than 5 tap, then this is positive. It can be seen in many akinetic rigid syndrome cases. This around 48-50-year young male patient, he presented with history of progressive sensory ataxia along with mild cognitive dysfunction. He was a driver previously, and since last 5-10 years, he joined the bank as a driver only. His MRI brain, mild brain atrophy, MRI spine, completely normal, nerve conduction study normal, CSF mild elevation of the proteins, B12 level, serum homocysteine, not CBC with MCV normal. Just see around the area what he is having.
कुठे राहतात? केशव. काय काम करतात? मुंबई. काय काम करतात? SBI. कुठे राहतात? केशव. काय काम करतात? मुंबई. काय काम करतात? SBI.
He's making some mistake while giving answer. What you do, he's saying Mumbai. So there was some cognitive impairment along with some frontal affection. So presence of such subtle orofacial dyskinesia, it is pathognomic for neurosyphilis. Though it is described in 20 to 30% cases of neurosyphilis, but if it is seen, it is syphilis. The other movement disorder described in neurosyphilis are Parkinsonism, myoclonus, dystonia, and classically neurosyphilis present with cognitive impairment along with sensory ataxia. So this patient has marked PDRL positive as well as TPHA positive. So we treated him with monosep for 2 weeks, 10 to 14 days. He improved. Even this orofacial dyskinesia, they also improved. Typical chorea patient. So this is spooning sign or choric hand, where there is flexion and dorsal arching of the wrist with hyperextension of the finger. So while testing this, you can see the spooning sign.
पकड़ा पकड़ा टाइट पकड़ा पकड़ा बस
Classical milkmaid sign or milkmaid grid, where patient alternately squeeze and releases the finger like a milking motion. So it is basically because of motor imp persistence seen in chorea. One more sign describing chorea.
निकालो भारी रखो
So again, because of motor imp persistent, if tongue is protruded, patient takes tongue in and out. There is one more sign described in chorea is pronator sign. Please see the tongue movement. How are these tongue movement in this patient? Patient is known case of psychiatry under neuroleptics. Oh. So she is pushing her tongue against the cheek. There is some component of akathisia also, apart from oral dyskinesia. So in tardive syndrome, you can get tardive akathisia, oromandibular dyskinesia. Retrocolis is very common in such patient, particularly with gastrokinetic drug. Sorry, not remembering. Levosulfiride. Yeah. Sorry.
परत जा
So this young male patient having progressive cerebral ataxia with imbalance while walking with tremulousness of the head. This is called as bobblehead doll sign or bobblehead doll syndrome. Basically, it is seen in young children. Rarely can be seen in adult. Sometimes can be associated with cerebellar ataxia and classically seen with expansile lesion or tumor in the third ventricular area. And all this tremulous movement they are because of pressure effect on the cortico-rubrothalamic fibers or dentato-rubrothalamic fibers. Last few slides.
मेरे सर में दर्द होता है एक साइड पे होता है राइट साइड में जब खांसी होती है ना तभी थोड़ा फ्यू सेकंड के लिए होता है थोड़ा दर्द
और खांसी खत्म होते सेकंड से रहता है ज़्यादा देर नहीं रहता
ज़्यादा नहीं रहता है
अच्छा नीचे देखो नीचे इस साइड देखो इस साइड हाँ देखो उस साइड
So basically, she is a case of cough headache. Any cough headache after the age of below the age of 30 years, always try to rule out CV junction anomaly. Then it is secondary cough headache. If there is no CV junction anomaly, then we call it as a primary cough headache. So any patient with cough headache or occipital pain, neck pain, always try to look for downbeat nystagmus, and that is called as Baroque sign. And this indicates underlying craniovertebral anomaly. So this patient had a Arnold-Chiari malformation, more than 7-8 millimeter downward displacement of the cerebellar tonsil along with peg-shaped tonsil. Last sign.
Right leg go down. Left leg go down. नहीं उठा सकते, कोशिश करो. नहीं उठा सकते, कोशिश कर रहे हो कि नहीं कर रहे हो?
So we'll see the description.
Right leg go down.
Then again we'll see the video. So this is Hoover's sign, used to diagnose the psychogenic or functional hemiplegia or lower limb weakness. Normally in supine position, when person try to lift one leg, the downward pressure is felt under the heel of other leg. So what is Hoover's sign? The absence of expected downward pressure from the good leg while trying to attempt the bad leg, and normal involuntary downward pressure from the bad leg while raising a good leg. So again I will repeat, absence of expected downward pressure from the good leg while trying to raise the bad leg. So please see the video again.
Right leg go down. Left leg go down. नहीं उठा सकते, कोशिश करो. नहीं उठा सकते, कोशिश कर रहे हो कि नहीं कर रहे हो?
So there is no expected downward pressure. So this is functional weakness. Sir, should I stop?
Yeah, I think it's 10 o'clock, so we can take some question and answers. I know that you've got many more signs, but you're going to do another session, no?
No problem.
So you come up to spinal cord. So cord, nerves and other things we'll give them in another class. So Rakesh, we want to take some questions. It's exactly 10 o'clock. Rakesh? Devashish?
Yeah, very good evening. So Girish, it was really phenomenal and wonderful session. It was a recap and amazing collection of videos, and you might have seen all the comments in the chat box also. And we all love your videos. So sincere thanks, and sincere thanks for allowing us to put it on YouTube also.
Yeah.
So there are very few questions. Like one is, what is the torch sign in PSP?
Basically, it is not described in the literature yet. I think I will show it. Should I show it, sir?
Yeah, please.
Basically, it is not described in literature. That's why we saw this sign in PSP patient. Not in all patients. See, in Mersenne sign, we demonstrate the blink with touch. So here touch acts as a stimulus in glabellar tap test or Mersenne sign. In PSP patient, already they have markedly reduced blink rate, less than 4-5 per minute. But when you put a torch light as a stimulus, whenever you put a torch light, they go on, they blink. If you switch off the light, again normal. So repeated torch light exposure cause repeated blinking in such patients. So we label it as a torch sign. And we saw this sign in PSP. So he is a PSP patient with markedly reduced blink, but with torchlight exposure, repeated blinking. We saw such torch sign in 4-5 cases of PSP out of 15 to 20. Not seen in all patients, obviously. That's why I omitted this slide.
That's nice. And then one of two small questions, like while in the applause sign, what exactly you have to elicit the sign, whether you have to ask the person to clap, or you should clap with him and then ask him to follow. So what is the exact methodology of?
You have to ask them to follow. You have to ask them to follow. show them 1, 2, 3. I read it as rapidly as possible to clap them, but some examiner they think or they want you have to clap it slowly.
Nice. Okay, and how will you differentiate between levitation and a goal-oriented behavior? It's not a goal-oriented behavior in PSP. I think that's not.
Arm levitation is not goal oriented. It is a spontaneous elevation of the arm while walking.
Fine. That's really wonderful, Girish, and we look forward to you for the next science, possibly for the spinal cord, the peripheral nerves, and the other things soon, possibly in the next month of August. And over to you, sir.
Yeah, no, I think it's a very good presentation. Girish always gives fantastic presentation. Shrikant also told you about very rare science. So I think it's been a very nice evening today. And if there are more questions, clinical science we're all interested in. We're all clinical scientists. So if there are more questions, don't hesitate to ask them to Girish or Shrikant or whoever. We'll try and answer. So do you want to tell what's coming on next week, Devashish?
Sir, possibly next week we have got some signs for the movement disorders, and next week we have got a movement disorder case.
Yeah. On the second weekend, second Thursday, Dr. Mohit Bhatt will be taking a class on movement disorders, and the first week there will be some movement disorder science. So it will be something like in continuation of what you had today. So Shrikant, you want to say something? Anyone else wants to say something?
Thank you for the opportunity, sir.
Thank you.
Anyone who is senior in the audience wants to say anything, you're most welcome. There's so many of them. It's a privilege, actually. There's so many senior people listening. It's fascinating. Okay, so if there are no other questions, let's say good night to all. And we'll meet next Thursday, 8:30. Good night.
Fine, sir. Good night, sir.
Good night.
Bye.
Sir. Good night.